Hi, I'm Jane Goodall and this is Nick, who's consented to a shoulder examination today. He has no underlying pathology and is fit and healthy. Okay, I'm going to start the examination by examining Nick's cervical spine and also core. So Nick, chin to your chest and chin to the ceiling, chin to the right shoulder and chin to the left shoulder, ear to the right shoulder and ear to the left shoulder. So we've looked at symmetry, just relax there, and if there are any tightness, I'm just going to palpate along the spinous processes. Any tenderness there?
No.
And I'm going to apply a little bit of pressure on your head. Any pain, numbness or tingling?
No.
Super. Okay, Nick, can you stand for the moment? That's great. So I'm now going to ask you to stand on one leg and squat 90 degrees. So we're looking for signs, and you can see a little bit of knee rotation there, hip drop, and on the other leg, that's great. And any torso instability as well. Okay, it's important that this is also done on an unstable surface like a cushion too. So I'm going to inspect Nick from the front, the side and the back, and we'll be looking for signs of atrophy, hypertrophy, fasciculation, any scars indicating previous trauma or surgery, and I'm then going to palpate from the sternoclavicular joint along the clavicle to the acromioclavicular joint, and just inferior to that is the coracoid process where the pectoralis minor and the short head of the biceps brachii attach. Okay, just put your hand on your shoulder there. So I'm going to palpate into the pectoralis and also near the axillary fold. I'm going to roll over the biceps tendon. Any tenderness there,
No.
Nick? And just relax. It's also typical that if there is any impingement, that the anterior aspect of the acromion can be quite tender. No tenderness there?
No.
Lovely. And then turn to the side. So from the side we can view the head and neck posture quite well, and also the thoracic spine. An increase in thoracic kyphosis could lead to an increase in cervical lordosis, and this can put a lot of fatigue and stress through the neck and the shoulders. And then turn through. So from the posterior aspect, we're looking for the same things again: scars, fasciculation, atrophy, hypertrophy, any scoliosis, and we can also observe if there are any obvious leg length differences as well. So we can palpate along triceps and also into the supraspinatus and the infraspinatus, and then along the borders of the scapulae. I'm just going to pop my fingers there. Nick, if you can take your arms out and all the way up. So we're looking, relax there down, general movement, nice and steady. 50 to 70% of the movement should come from the glenohumeral joint, but if there's pathology there, then the scapula will compensate for this. We can then, if you just walk over to the wall and do a little bit of a press up against it, so push up and look for winging of the scapula. So if there's a medial and superior winging, it would indicate a long thoracic nerve problem. Okay, come and sit. Well, just actually. Okay, so we're just going to perform a few combined movements first of all. So if you want to just take your hands behind your back, Nick. So this, we can see abduction and external rotation. Then reach up with your thumbs behind your back as far up as you can go. And it's normally around T4 to T8 level. That's wonderful. If any limitation or restriction in range of motion, we'd then go on to do a full active range of motion. So if you lift your arms up, raise them as high as you can. So we're looking for about 150 to 180 degrees of normal flexion, and then keep them straight all the way back. About 40 degrees of extension. That's lovely. Lift your arms from your side all the way up, Nick. And we're up to 180 degrees, and come back and take them across your torso. Lovely, it's about 40 degrees adduction, that's wonderful. And then rest your arms, bend your elbows and take them, rotate them down and rotate them up. So about 80 to 90 degrees of external rotation there, that's lovely. So if you'd like to take a seat, I'm going to passively examine Nick's shoulder now. So if you can fully relax for me, that's wonderful. And I'm going to feel for signs of crepitus, the quality and range of motion there, any resistance. That's lovely. Okay. Great. And relax there. Wonderful. Now relax your arm down. That's super. Okay. I now go on to doing some special tests here. So if we'd managed to produce a little bit of acromioclavicular discomfort or pain, we could try and exacerbate this by pushing down on it. Just relax their neck. I'm going to bring it and do the crossover test. Any tenderness there?
No.
So any tenderness there could indicate there's possible arthritis. There could be a clavicular osteolysis, or there could be acromioclavicular separation, and we could inferiorly distract the shoulder and see whether the clavicle elevates or not, which would indicate a separation. That's lovely. I would then go on to do some impingement tests. So the first one I'll do here is the empty can test. So what I want you to do there, Nick, is just resist me as I press down. And this is any discomfort there.
No.
If there was discomfort there, it could indicate a supraspinatus tendinopathy. If there was a tear, a very large tear, the arm would drop down to the side. Okay, so other tests we can do there to isolate various rotator cuff muscles. One is the Gerber test. So if you just push your palm against mine, that's lovely. Any discomfort?
No.
Wonderful. And the hornblower sign, so just relax your arm there, your elbow. I'm going to try and take it forward, just resist me. Okay, any discomfort there?
No.
Which could localise more the teres minor, that's lovely. And then just relax off the deltoid there. So push your arm outward into rotation against me, that's lovely. Any discomfort there?
No.
And that could indicate if there was any tenderness there, any infraspinatus tendinopathy. That's lovely. So I could then go on to do the Neer's test. Any discomfort here? And this sort of pinches both the biceps tendon and the supraspinatus against under the acromion. That's fine, just relax there, it's lovely. And then the Hawkins-Kennedy test. Okay, lovely. I'm just going to put this into rotation quite quickly. Just relax there. Any discomfort there?
No.
Okay, and that if there had been discomfort there would have indicated some subacromial impingement there too. So we then go on to looking at a superior labral anterior posterior tear test, and one of the most accurate ones is the Coombs test, which is 90% accurate, and this involves 3 movements. So the first one, I'm just going to lift that up and I'm going to exert a bit of pressure down here. Just tell me if this causes any discomfort.
No.
Okay, that's lovely. And the second one is a sulcus sign. Just relax there. So I'm distracting the shoulder, see whether there's a visible or palpable sulcus there. No discomfort?
No.
Great. And the third one would be a Jurgensen's manoeuvre. So you're just going to twist your palm up against my hand. Any discomfort there?
No.
And that would rule out also biceps tendinopathy there. So if all 3 are negative findings, there's only 6% likelihood of there being a slap tear. If there's 1 or more positive findings, then we would be requesting an MRI. Whilst we're also in this position, we can also just test for any instability in the joint itself. No problems there.
No.
Wonderful. Okay, and then if you'd like to just lie onto your back for me, please. Okay, we could also further test by doing the apprehension test. So any discomfort?
No.
Frank's test, which is moving the joint throughout different ranges, listening and palpating for any pops, clicks, which would indicate a little bit of instability there. Okay, that's great. Lovely. Okay, would you like to just sit a little bit? That's great. Okay. So I would perform a very brief neurological, and we test sensation. So Nick, you're just going to feel just a light touch like that, and I want you to close your eyes and say yes if it feels the same. Okay, and we'll be comparing bilaterally.
Yes.
C4.
Yes.
5.
Yes.
6.
Yes. 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 Yes.
T.
Yes.
T1. T2.
Yes.
T2. That's lovely. And then I would test his myotome. So if you want to just sit up for me, Kevin, swing your legs round. That's great. Okay, so I want you to just shrug your shoulders up. That's C4. Push them out. C5. And then just push up with both elbows. That's great. C6. Push down. C7. And then wrap your fingers around mine. Try to stop me from opening them. C8. That's great. And then bring your fingers out. Try and keep them there. Stop me from closing them. T1. Okay, that's wonderful. So, to conclude the examination, I would always examine above and below the area. I would perform a full neurological assessment, and if required or indicated, I would request further imaging. Plain radiography is quite good for identifying calcific deposits, any anatomic variants, and EMG if there are neurological considerations, and MRI. But here we have a completely normal findings. Thank you very much, Nick.